Welcome to the Big Debate Live. My name is Concepta Wayment and I am VP of Transformation with Healthcare Communications. Today I will be question master and I'm coming to you from Cambridgeshire. Joining me on the virtual panel from Surrey is Steve Leivers, Financial Turnaround Director, NHSE. From Hertfordshire, Jim Gray, who is a consultant orthopaedic surgeon and clinical director at the Luton and Dunstable Hospital. And finally, joining us from the north of England is Phillipa Winter, an ex-clinician who is currently CIO at Bolton NHS Foundation Trust. A few housekeeping issues before we start. There may be time for questions at the end, but if you do have a burning issue, please add it into the chat rather than interrupting the debate. I can't promise we will get to it, but we will try our best, bearing in mind that we need to be conscious of time and the number of questions we can debate in the time allotted. I'll be putting everyone on mute shortly and would ask that you remain mute for the duration. And if you could make sure your cameras are switched off, you'll be able to then see the panel. And just to remind you, we are going to record this session. Thank you very much to the panel for joining me today. Let's start with you, Steve. So, the government has written off all NHS debt. What impact will that have on healthcare providers and their ability to invest? And where should financial directors be focusing their spend?
Hi, afternoon. Thank you for inviting me. I think it's a terribly interesting statement that the government has written off all financial debt. And so what I wanted to do, first of all, is explore what that means and explain what has been written off and what hasn't been written off. So what the government have done is they've written off £13.4 billion of historical debt. And historical debt means debt that's been acquired or built up over a period of time. It doesn't include the gap between how much a trust earns and how much the trust spends. So there are currently about 100 trusts that have been affected by this. So there are 100 trusts in the NHS that are recognised as having long-term historical debt, and that historical debt is or has been historically reapproved on an annual basis and then funded by the Treasury through Treasury loans. The problem with that is that Treasury loans are expensive. They're about 6% for new debt and about 3% for aged debt. And to get from new debt to aged debt, you have to pass certain criteria. So essentially, if a trust owes £10 million, then it's paying every year about £600,000 of debt on that. And so what the government have done is they've really written off the debt from trust balance sheets, but not from their P&L accounts. And what that really means is that all other deficits or all other shortfalls exist. And those are the deficits that exist. The largest one of them is PFI funding. And there is £55 billion of outstanding PFI debt that still exists, that hasn't been touched. And so trusts who have PFI facilities are continuing to pay that. On top of that, the gap between how much trusts earn and how much trusts spend, so the deficit in the NHS, in 2018-2019, which is really the last full year for which figures were available, stood at £12 billion. So £11.4 billion of debt has been written off, £12 billion of shortfall or debt or deficit still exists across the NHS. Other factors that are worth considering within that conversation quickly before we go on to talk about how we manage it. Last year, in 1920, only 70% of all savings that were planned to be delivered were actually delivered. So trusts had a gap between what they earned and what they said they were going to save. And there is a view now that's supported by the NHS and by most of the bodies that commentate on this, included bodies like the King's Fund, believe that we can only achieve medium-term and long-term financial sustainability by changing the way we work, by developing new ways of delivering care and new ways of operating. And that those operating policies need to be confirmed going forward. And we have 12 underlying principles of what we think we're going to have to do to accommodate things going forward. The most important thing that we have to do is consolidate all of the gains that we've made so far. And COVID has caused us to change the way we operate in a way that we haven't managed to achieve in my lifetime in the NHS. And what we don't want to do is lose those gains. We do need to separate, and we're being instructed to separate COVID sites from non-COVID sites. So trusts that have more than one location will have COVID and non-COVID sites. And you could call those hot and cold, but effectively they're COVID and non-COVID. There will be a move towards more centralisation of specialist services. And if we think of those big services as being things like neuro, cardiac, those things that we all traditionally know as being the specialist services, we will centralise them, and many of those decisions will be taken out of the hands of local decision makers. There will be, now these are not necessarily views that everybody would endorse, but they're certainly where we're going to go in this direction of travel. We will share elective waiting lists across ICSs. We no longer will operate as sovereign organisations where we can stand as islands of success in seas of disaster. So all waiting lists will be shared. Commissioning will move towards more of a population health base. So we'll move away from where it's been. There will be a radical shift away from hospital care, and we will develop more community services, and we will develop different and better ways of working, particularly for people with long-term conditions. And there will be, I think, a radical new approach to managing people with long-term conditions. If I were to put these in a list of what I think are most important, I would put the next one last. But for obvious reasons, the ones I've mentioned so far preceded. But there will be a disproportionate focus on people with unequal health outcomes and unequal access and capacity. So we will start to focus on those people who are less able, who have less ability to look after themselves and who need more care, and we will prioritise those people. I'm not sure we haven't been doing a lot of that already, and people like Jim and Phillipa will have a view, but definitely there will be a stated focus on those people going forward.
So, Steve, you're saying really it's almost a bookkeeping adjustment, and trusts will still need to save money, but what's going to radically change things is COVID rather than the financial write-off? What
I'm saying is the financial write-off came as a response to COVID. My personal view is that financial write-off is more totemic than real. To write off £13 million worth of debt is huge, it's vast, but it was never real debt. It won't change the operating budgets of a single trust.
Okay. Phillipa, what do you think?
So I think, yeah, I agree with everything that Steve says. I think putting it into perspective and working in a trust in the Northwest, you know, the writing off of those costs isn't impacting us operationally. Yes, we've been told, you know, that so how that plays out is, so in my budget, I've now got to keep within budget. I cannot go over budget by no means. So all that, although the debt's been written off, it's by no means over. And if we want to do any development, and if you think also around with COVID and the developments we need to do to keep in budget, it's quite difficult. So we have to do the transformation, and we have to look at the CIP, which will then help us to develop further. But to do that, and as Steve says, for me, it's really important, the piece around the ICP, but also the STPs, which is for me, Greater Manchester. and how that will look. And there's a massive impact. So Bolton itself is the second busiest A&E in Greater Manchester. We are Women's and Children's Hospital for maternity services. We are very much a red, or rather than green, or a COVID, or what, because of the nature. We don't have two hospitals like some do. So, and that you can then absolutely extract that. But it doesn't mean to say we're not looking at what we can do, but there are massive changes around absolutely isolating and protecting not only staff but patients.
Yeah.
And how we manage those pathways. And we will have to do that centralised, and those conversations are already happening at STP level. And like your PTLs, you know, your performance league tables and things like that are all being discussed more centrally. And then how can those patients be managed? Now, in one way, you could say that is what we need to do to keep people safe. But then there's obviously an implication of that if you're travelling across a whole large area, you are also disenfranchising some of your patients. However, it's like when you're an inpatient now, we can't have visitors. So COVID has had a massive, massive change. The NHS will never be the same. But with regards to funding, it's certainly not over. And actually, for us to be smart, we need to do that wider and with our partners. And when I talk about partners as well, that's also with our suppliers. And we need to be really acute at what we can provide around collaboration to make that best value for money.
Okay.
So for me, the same whole system approach. We have to keep within budget. I've not got all of a sudden all this freedom to do what I need to do. If I want to make changes, I need to find savings to do that.
Okay, lovely, thanks. So let's talk then about antibiotics. Jim, we've seen a rise in resistance to antibiotics. What would happen if antibiotics stopped working completely, for example? Do you foresee another pandemic, for example? Oh, I think he's on mute.
Can you hear me now?
That we can, thank you.
Usual. That'll play to my strengths on a later question, I think. The World Health Organization has always been acutely worried about antibiotic resistance. It's a massive global issue. The disseminate use of antibiotics is critically a problem. Now, to kind of focus the mind, coronavirus is not something that is antibiotic related directly. Coronavirus and COVID have been a sort of condition that have had to be managed and not cured. Antibiotics don't have a direct place in the armamentarium for coronavirus, but they come into play when you've got patients who are otherwise susceptible with other comorbid conditions, who are then suffering with the bacterial pneumonias that then develop. And if you're then facing a pandemic, you're adding a pandemic onto a pandemic if you then got increasing resistance. We're all clutching at the hope that either a vaccine or immunity are going to become available. And quite frankly, I think neither of those are certain. Yes, there are trials going on. There's hope. You know, we clutch at the kind of the light at the end of the tunnel. But I don't think we've seen the end of, this is not a solitary pandemic. We're certainly going to see epidemics. We're certainly going to see endemics. The flu and the vaccination program still kills people. Back to antibiotics, what we've seen recently is a catastrophic effect of a terrible, highly sort of fatal virus. But if you add antibiotic resistance into that equation, then the problem just gets greater. I heard recently that dentists who have been clearly social distancing their work and their practice from their patients have been prevented from seeing people. And the easiest thing for them to supply effectively is a bottle of painkillers and a bottle of antibiotics. So the problem is not going away. Coronavirus is not really caused more of a problem with antibiotic resistance. But when you're trying to manage a COVID conditions and you're clutching at what treatment you can give, it's very easy to think, well, coronavirus mimics quite a lot of things, whether it be a menopause, a hangover, or flu-like symptoms. You're clutching at, well, pneumonia, well, let's just chuck some antibiotics at it. So I'm sure there's been a great deal of prescription of antibiotics which not helped the problem. But yes, I think an ongoing World Health Organization issue has for many, many years been moving from one antibiotic regime, tackling resistance, local microbiology units and regional centres trying to monitor the incidence and prevalence of certain bacterial infections, and thereby trying to coordinate the use of antibiotics. But it needs a bit of strict control. You know, the newer ones that might be effective end up being very expensive, then they end up being used more. The older ones tend not to work, so that we go through this sort of ebb and flow of use case for antibiotics. But at every stage, the evolution of a fast replicating bacteria is such that the survival of the fittest, like we've evolved in our planet. So they'll get around it. It's a big problem.
Thanks, Jim. Phillipa, what's your perspective?
I think with regards to pandemic, I'm not really that clinically, as an occupational therapist, I can't talk about antibiotics, but with regards to pandemic, I think we can't be naive to think there's not anything more, like Jim said, really. But for me, it's more around how do we manage this winter. So obviously COVID's not going to go away. We know that for the next 2 years, because we won't have the things in place to support us with that. But then how do we manage with our normal flu season, with all the other things, RMRSA, and all the other infections that we have to support and deal with to keep our patients safe and protected when they're in hospitals. So I think that's where I think the NHS from now is learning more around how can we manage that, especially if you've got a really old estate, really old hospital that have got 6-bedded bays, you know, and how can we look to manage that better in the future. So here at Bolton, we're looking at how we create more side rooms, because we're not a new PFI building. And I think those are the things, the changes around the state that need to be done, and I think hopefully the government will support that. But going forward, we can't be so naive. I think we sort of knew that this was coming, and also how we can be prepared around the PPE and, you know, a lot of the anxieties that there's been had around the preparation for this and accessibility and the transporting of those sort of things. I think we've got to learn the lessons from that and understand how we can manoeuvre those things faster and quicker. But for me is also how do we manage that going forward. I know we don't really have season times anymore in the NHS. It's an ongoing, but we do know obviously over winter we've got higher increases of respiratory disease, your normal flu season, but then all the other things and infection control issues that we've got to support. So
leading on from that then, what do you think are the lessons learned from COVID-19 then for the NHS, and what does it need to learn? What are the implications of returning to the old normal, I suppose?
We will never return to the old normal. The normal, and let's face it, the NHS was under a great amount of pressure, and I think the one thing from COVID, the positivity has been how the NHS has rallied together and been really agile, and had to be agile and demonstrate change at speed. But also I think there's been some real positives about system approach and how we've worked alongside our partners in public health, in the CCG, primary care. Here in Bolton, I provide services for hospital, community and primary care. So from that point of view, we've instilled major change. But that's been done because of the command and control. As we all know, in NHS hospitals, there's a lot of bureaucracy, there's a lot of governance and assurance, which is the very right thing to do. However, I think the one thing personally in my organisation, I think in others, has been that command and control and that very quick decision making on making changes and actually actioning them. But it's also been giving the permission from the executives and the right people from gold, silver and bronze to actually absolutely deliver that, but been at speed. And from my point of view, I wouldn't want to go back to where we were, because I think we've really transformed the NHS. And when I speak to my peers nationally, in the last 11 weeks, which would have probably took us 2 to 3 years to do in any other time. So, you know, we're not going to go back, but what we need to do is look at how do we make our new normal robust, safe. We obviously have got to increase all the policies now, because we've done lots of things at speed. So we need to take stock So from that point of view, I think there's a lot of positive come out of that. And as I say, with the command and control, I wouldn't want to change that. Now, I know there will be some assurance that comes back, but I do believe, because obviously this is going to go on for longer, we will continue to do that. It won't be a daily thing that we have had at the height of obviously COVID, the pandemic, but we will keep that in. And at the moment it's twice weekly, which you can then at least, you're not waiting monthly for decisions to be made. So that's been a real positive thing, but also the working across Greater Manchester and locally, and also identifying that it's all one part of public money. That actually we need to pull those resources better, but also breaking down some of the boundaries. So working with care homes, looking at how we can work differently, reorganise the staff, redeploy the staff into the community to manage people at home so they're not coming into hospital, and managing those long-term conditions. Those sort of things will never go back, because actually we've demonstrated we can impact on the admissions to A&E, and we can impact on managing those people. We can impact on them also not going to the GP. Those are really, really healthy ways of working and pathways that we can't change.
What do you think, Steve?
I agree with what Phillipa's just said. I think that sharing will be, it won't just be something that we all think about in a very non-specific way. I think it will become established, and we will stop over the last 10 years, we've developed little islands and we all work on our own. We help each other, and there are great networks, things like ICU networks, things like maternity networks, but overall we work independently and separately. And I don't think we'll go back to that. I think we'll continue to work our systems to the extent that even funding is being shared. So we have funds that most people on this webinar will know about. FRF, financial recovery funding, which was the old PSF or STF, that won't be allocated to an individual trust or organisation. That will be allocated across an ICS. Control totals, we'll share those sorts of things. And success will be measured by all of us doing well, rather than small individual organisations or big individual organisations doing well whilst others flounder. And supporting others will be what we all do, what we used to do and what we'll do again.
Before I come to you, Jim, for your sort of on the ground experience, we've just had a question come in that said, how can suppliers help you to achieve the new normal?
So for me, that's quite easy. Now, I'll probably talk a bit later around being bombarded, and that's one of the lessons we need to learn really is being bombarded with the free opportunities that we've been given for a certain period. Now, some of those are absolutely great and important, but for somebody in my sort of position and others, COOs, CFOs, we need to be really cautious about, that people are obviously wanting to support, but then at the end of the day, there is a legacy and there is a cost that needs to be paid from that. So we need to be really, really thoughtful about what we're trying to achieve. And that goes back to that ICS thing around being bigger than just one organisation, and how can we impact and use that technology across the system. But also what I also talk about is sweating the asset. And when I mean sweat the asset, it's not about making it 10 years old and I'm still using it, but it's about absolutely using every single part of that technology, but also changing it and tweaking it. So for instance, in the national programme, we were supported within having Attend Anywhere, and lots of organisations took that up. It's one of many video consultations that we've got. But obviously, as an NHS programme, we took that on board. But then we need to review what's right for the future, what's cost effective and what's best, because in the GPs in my area, we use AccuRx because that was supported for primary care. So I think, it's really important to understand and those lessons around what are we trying to achieve. And some of the best relationships I've got with suppliers are around when I say to them, I've got this problem and I want you to help me solve it. But actually, I want you to work with this supplier because I like what you've got here and I like what you've got there. and I don't want to be agnostic because actually you can't give me the package. So, and I've done some really great work here with my team and suppliers around really collaborating, and they get obviously something else new that they can sell, which is great for them, because at the end of the day, that's what they're about, and I understand that. But I think it's about understanding the new world and actually thinking around how can they collaborate with others to really find that sweet spot that we're looking for. And that sweet spot is around collaboration across health, social care, and how we can do it. And that's in lots of things, video consultation, you know, the way we have portals, lots of different things, patient entertainment, you know, how we use AI and what that links into. So for me, it's not just about working with me, it's about working with me to solve a problem.
Okay. And Jim, your experience on the ground, and I'm just going to add into that, we've had another question pop in that's very relevant, which is how do we get patients to accept the new normal?
So I think it's really interesting, and kind of the summary of what has been said already on this question is I found that actually particularly invigorating. And now I don't know if I'm part of the majority or the minority. My glass is half full. It's not half empty, it's half full. And so I have been, I don't know if I'm embarrassed to say this, but quite excited during the whole surge of COVID, because it has allowed me as an individual to start thinking innovatively, more so than normal. And as Phillipa said, it has for some it's led to an opportunity for people to start thinking in new ways. It would be an utter tragedy to go back to pre-COVID norm. And if we did that, then we might as well kiss goodbye to society, because we've got to change. And this is a moment in anthropology where the chapter has already started being written, where people will then say, and then there was this horrible pandemic that mimicked everything, and everyone had to keep away from everyone else, and lots of people lost their jobs. Out of this, there will be a phoenix that comes out of the fire and flies. Now, when the pandemic hit us, we weren't frankly really ready. The juggling balls were sort of being thrown up and kept falling, if you like. And the difficulty that we had was a lot of firefighting, the sudden switching, the cancelling, the moving, the planning, the replanning. And the resourcing of that was terribly tiresome and very fatiguing. But what we need to know for kind of future, a future second surge, a future different pandemic, COVID-20 or whatever number you choose, is that actually what we've had so far is we've lacked a degree of automation, and actually trying to manage a problem without data insights or defined protocols or sharing of experiences across a whole health network has been a bit of an issue. And so we need to be prepared for those balls to be thrown up again. It might be very soon, but we need to be in unison with our partners. What we have to our advantage is the word national in our national health system, which means that we can start acting together and entertaining our joint intellectual property. And in effect, coming back to the first question of what will we do from a sort of financial perspective, what has already been said, and really kind of in summary, is that there's a great deal of expertise, intellectual property within the national health system. And it's about sharing that. And frankly, if this country wants to sell that abroad, then great. But let's get suppliers, commercial entities to work with innovative minds, whether it be, you know, CCIOs, orthopaedic surgeons, financial directors, or whoever, putting ideas together and being the entrepreneurship of the NHS. That's what I want.
Brilliant. Thanks, Jim. So let's keep talking digital then. Phillipa, how do we develop the existing workforce to deliver a digital future?
So there's two angles to this really. So there's one which we talk about is a digital literacy workforce that are literate in informatics. And that is one thing around culture and change and how we invest in the training for our clinicians of the future, but also how we engage with our staff in organisations to do, which is really passionate for me, is around user-centred design. And it has to be, because at the end of the day, you've got a shiny bit of kit, it doesn't necessarily work for everybody. So we've got to stop doing that. We've got to understand, like I say, what is the problem? The clinicians and the staff know what that is, and then how do we achieve that in the best way? So there's two ways. There's about robotics and a digital workforce like a robot, but then there is the digital literacy. And we all know that in about 10 years' time, I think every school leaver we could take up and snap up in the NHS's establishment. So we can't do that. We won't have enough workforce. We're already struggling with nurses and other professions. So what do we do now to prepare ourselves? How do we look to retrain and redeploy staff? So for me at Bolton, it's really important that we need to look at machine learning, not only around processes and back office services and how we can make that easier. So for instance, even with COVID, now we've got COVID antibody testing that we all need to provide. We need to provide the evidence of it. That should be automated. You know, these are things that are not going to go away. If you get a negative test, you need to be invited back as a staff member to come back in 4 weeks to have that redone, or in 6 months to see that you've still got your antibodies. Those are the sort of things we need to automate, and those are the sort of information over an STP we can share around agency staff, and also not be all testing different people for different reasons. So automation is really key, and that's where I'm starting to look at where we can take that, because you know, we won't have that workforce of the future, so we need to start now and we need to look at that. But then second to that is the digitally literate workforce. And we can only do that through engagement and through training. I'm really lucky here in Bolton. I've got a whole group of CCIOs and associate CCIOs. I was a CCIO before I was a CIO. And for me, everything I do is around that user-centred design. But likewise, we've just put out a massive electronic patient record here in the Trust. And in COVID, we've had to react really fast in changing some of those pathways, because obviously to help clinicians, because we're now on electronic, and it's about being that responsive partner within the organisation, as informatics should be, rather than that barrier, if you see what I mean. So we have a duty to work with our workforce colleagues, with our clinical colleagues, the medical director, Caldecott Guardian, you know, your CSIRO, to really drive that belief. But now what I think as well we need to do is drive that more into your public health and your social care, and actually how we monopolise from COVID on those big conversations around how we're going to manage our citizen. And to do that, our workforce are going to have to be literate, because digital is a facilitator to a lot of that. But we need to bring staff alongside with us. You know, we can't just expect them to do that. But if we engage with them and have really good key stakeholders in our development of our programmes, and when I talk about that, I talk about operational teams as well, because if you've not got the operational and the clinical teams involved, you will fall at the first hurdle. So engage.
Definitely. Jim, what are your thoughts?
So I talk a lot about trying to find a sweet spot between clinicians and the corporates, the people who are going to be able to build the ideas, that the coders are going to build the technology. It goes back exactly to what Philippa's just said, and this is unfortunately not a debate. I completely agree that actually what I've tried to push forward with the stuff that I've done is back to, as Philippa says, the user-centered design. If you've not got a clinician in the room, but the clinician is then the user of a system, then frankly you won't have a usable system, and you'll get denial of that system. And I'm not sure if it's really about the workforce, particularly in answer to your question. I think it's slightly easier than that. I think the overwhelming proportion of people readily access technology. You know, you're 98% of the population that are well versed in opening up an Apple iPhone, ordering something on Amazon, or searching on Google. There's not an 8-hour training program for all of that. And these are very, very powerful and very profitable companies. And the reason they're profitable is the fact that you open a screen and it is dead easy to know what to do. When you're in the workforce in healthcare and you're looking at 1990s software, and your patients are sitting in waiting rooms, frankly, probably banking online whilst they're waiting, ordering their shopping, or checking into an airport. I work at Luton and Dunstable Hospital. There's, you know, that they could in COVID-free times could be checking into a flight once the clinic's ended, but actually they have no idea what's going on in the clinic itself. And so what we need is user-centered stuff that's not 1990s software, is not old hat, not giving the right data for the managers, not giving good customer satisfaction. Let's dare to call patients our customers, and not giving the clinicians the tools that could make them much quicker. So I think the sweet spot between embracing a future digital workforce is actually just saying to people, don't come into a hospital and get yourself lobotomized as soon as you go through the front door, because we seem to just accept paper and word of mouth and fax machines and bleeps on the ground, where we would never accept that outside of work. We've all got powerful stuff in our pocket, so hey, guess what, it's free too. Not entirely, of course, because you've got to design these things, but user-centered design to focus on not just clinicians and make patients wait, and not just patients and make clinicians wait, and not design solutions that don't give the right data for managers. You've got to look after your patients, clinicians and managers. And it's not so much about the digital workforce as much as the digital tools that the workforce can use. And if it's user-centered design, you open up the machine, the tool, the software program, and it should just take you through it like Amazon and Google and Apple iPhones do. So I think it's about user-centered design. I completely agree with you, Phillipa.
Lovely, thanks. And this final question is a big question, so I think it will be our final question before we open up to Q&A. And I'm going to go back to you, Steve, as you started the session for us. What does collaborative working mean for you in the context of an ICS? And what are the main drawbacks to making it happen?
Can I pick up some of the things we've just talked about? I think some of those are drawbacks. I don't know if anybody's read the piece today online by Professor Carol Sikora, who's a terribly well-known clinician. His view is that we've got a disease, COVID, which is not a one-size-fits-all disease. It hasn't attacked everybody equally. It is definitely differentiated between people who are elderly and people who are young, between people who are of different ethnic background. And definitely we now know that if you come from Bangladesh, you are more at risk from COVID than if you come from a Northern European country. And yet we are applying the same rules universally across what we do, both to treat COVID and to treat the NHS. And this argument, this piece that Carol Sikora has written, argues we should stop doing that. And we should look at our society selectively. We shouldn't, and Jim, I'm going to argue with you slightly, we shouldn't refer to there being a new normal and an old normal. The old normal is normal, and we mustn't throw away all of the liberties and all of the achievements and all of the great advances we've made because one disease came along and decimated us. And I think it's a really exciting piece. I don't know what the right answer is. I have strong views on both sides of the argument, but I do think it should give us pause for thought to work out. And Jim, in your area, you have a very high population of people who are in that high risk group because of their ethnicity. And if we treat those people the same as, say, Newcastle upon Tyne, where I was originally from, in Newcastle and Gateshead and Middlesbrough, where they have been decimated, they are principally Caucasian, English-born, white, with almost no racial diversity. I now live in London, where there's a huge amount of diversity, and I do think we need to think about that. And we need to think so that what does collaborative working look like? We've fallen into a trap of believing that Zoom and Teams equal virtual working, and they don't. They're part of an armory, part of a set of things we've got which will help us. And we do need to move toward virtual, because if we keep treating the same number of patients, the two people in the room from trusts are seeing 1 million outpatients a year, or close on those numbers. And we can't continue to see all of those people in all of the ways we currently do. But just moving them from coming into our outpatient clinic to being seen on a virtual clinic via a Zoom or a Teams is not a good solution. We need to find better ways of working, better ways of treating other people that stop considering hospitals as the end product. There is a view, and it sounds trite, but it's that we must move towards a talk before we walk principle of care. So people have to have spent time with their GP. We have to work out what we need to do for people. And people with long-term conditions, we need to stop them walking into our acute hospitals and treat them where they live and where they are. And we need to make sure that the care we deliver in those areas is adequate and appropriate for those individuals. And we have to keep people out of hospital.
I agree. I think if we do digital first, then you can. Obviously, there's an accessibility issue, and I think that's something we could talk about all day. But there are so many ways, aren't there? And there's so many different people who want to access their healthcare differently. So I've got a 70-mile commute, and my GP is obviously near my home. It's really difficult for me to get an appointment. But I have to say, since COVID, they've sent me out a questionnaire. Somebody's rung me 2 days later. I've been delighted what experience I've had, you know, from that, because I don't want to go to the GP unless I really have to, or I want to have a video call. But actually, I didn't even do that. I just did a questionnaire and then they rang me back. So I think it's about understanding, isn't it, how people want to access those, but also in regards to how we do public health, health promotion, using apps, and then obviously developing into wearables and how that people that do take control of their own health can manage that. And then we see people by exception rather than the norm, and we see people in relation to their needs of their health condition. And I think that's some changes that's coming, but it's going to take us some time to really develop that. But I think in COVID, we've had to react fast, and the teams have been redeployed to work more in the community and support GPs. And we don't want to go back. But to do that, we need to be really smart and think differently, and also about how each individual might need something a little bit different.
Absolutely. Can I respond to that? Because wearables, I think, is a really cracking example. If an individual has asthma, they can download an app to their phone which will Bluetooth to a machine. They blow into this machine every day. It will download it via Bluetooth. It will download it to their GP, either every day, every week. So, Jim, what you were talking about. And that GP can now manage an individual's asthma. Or if you have an Apple Watch, it will do an ECG for you on a daily basis if you tell it to. All of those things are where we need to go. And if we do that, in northwest London, they have the largest renal dialysis service in the UK. And everybody's data is on an app on their phone, whether it's a Samsung or an iPhone or whatever it is. So if I have renal failure, I and all of my family who I give access to can see what my urea and my creatinine are today. And I genuinely do believe you're right, Jim and Phillipa. Look, that is the way that we need to go. That's what collaborative working is.
But then I'd push that further. Then you would use your machine learning, and with the machine learning, you would get your exceptions.
Yeah.
And you can be managing people and also identifying escalation far sooner than you would normally in waiting in between appointments. Like you say, we need to check that people are deteriorating and deal with it quickly. But that can also be done through triage from not the doctors as well. And that's not around saying we don't need doctors, because we do. But it's about making sure that doctors and specialists are available, because in the NHS we'll always need that human interaction. But it's about making sure that that time is quality and that those specialists can use that time when and where needed.
Absolutely. And we're never going to replace people. So, Jim, we're always going to need you when we fall off our mountain bike and break our leg to put our leg back together again. And we're not going to be able to do that virtually. So we need to be just appropriate about what we do and how and where.
But then,
my particular thought on automation is getting that data and then actually offloading a lot of those human tasks so that humans can be human again. Eric Topol put it very nicely that actually, you know, it's not taking away jobs at all. We need to invest in human empathy, which is why I became a doctor and why many doctors and nurses went into that profession. but actually we're dragged away from that, banging our heads against keyboards that don't quite work, or trying to filter through bits of paper and trying to look for the red one or the pink one or the yellow one. And actually that's taking time away from the hand on the knee, the empathy, the cancer diagnosis, the human empathy that we absolutely can't get rid of with a robot. But if you can give clinicians the tools with data to automate stuff so they can see what's coming around the corner, and to see that the mental stress levels or the peak flow in the asthmatics is going to take a downturn, predicting what's going to happen with your renal function, because the machine learning and the AI module are able to predict that, as McLaren showed us with looking at pediatric ITU units some years ago, when this child is going to fall off their perch on the unit, because it understands the data. That's better than any human could hope to be. We're not going to evolve into that. We need automation.
Indeed.
Jim, while you're answering a question, we've just had a question come in from Francis. Is a second COVID spike over the coming flu season preventable or inevitable?
I think at the moment we're trying to equilibrate with a big societal experiment. This is not a question necessarily for a clinician. I'm not a microbiologist, a virologist. You know, I put bones back together with a hammer and screws. So it's not per se a clinical question. We could all answer this, but I think the sense is that what the governments are trying to decide, and Public Health England are trying to decide on how to relax lockdown. It's a big unanswered question. The effects of that we'll know in a couple of weeks' time as we relax. And you know, if we do get a second surge, it'll be related to that. We can't relax too quickly, because then the surge will be bigger. And I think, as they sort of outlined initially, and I get this, you know, you're trying to protect the NHS, but you're going to have these waves, these little ripples. We're not out of the woods at all. Before COVID, we were on a constant winter pressures. You know, the summer was hitting winter pressures. There is no seasonal variation. It's all difficult. Now we're on a go slow as we try and get back to normal. But believe me, clinically, trying to get through the work in current times will be even more difficult the quicker people in society relax. I think we are only just round the corner from another potential horrifying surge. So we've got to be agile. And it goes back to the element of what we talked about earlier on, of try and maintain the ability to be opportunistic and agile. And yes, completely agree with you, Steve, that you need to take the great advantages that we've had of old. This is not talking about tearing up the rule book. It's about trying to seek all the good outcomes and the good practices that we've seen recently. We've really focused our mind with COVID because it's all happened so very quickly. You couldn't do half the projects we're trying to do in less than 5 years. But you know, we're trying to ramp up these things within days and weeks. So it's trying to find the opportunities and the glass half full.
Yeah. Can I just say one last thing, Concepta, about collaborative working, and it picks up a point that you made, Phillipa. We need to stop all having individual shared services that we can share. So things like HR and workforce, things like payroll, things like finance, things like how we look after our estate and how we manage capital. Across a region or an area or an ICS, we should share that, so that we can take the money we're currently spending on that in every hospital and put that back into supporting the developments we're talking about. Unless we fund digital, it won't work. And Jim, you're right. We've all worked in the NHS for years and years, and we've had outdated equipment forever. We've got to acknowledge that and do something about it. We need to recognise we're not going to get a huge amount more money, so we need to find different ways of funding that, and stopping duplication of expenditure on crazy things. I think is the easiest way to do that.
Great.
Thank you. We have run slightly over our 45 minutes. The panel have kindly agreed to stay on for a few more minutes and open up to any questions from anybody that's listening in. So if anybody does have a question and wants to switch on their mic and ask the panel anything for the next few minutes, please feel free to do so.
Nobody likes us.
We're all ready for dinner.
It's nearly lunchtime, isn't it?
It is.
Lovely.
In Cambridge, Phillipa, it's called lunch.
Oh yes.
Bolton, it's called dinner.
No, I'm always getting told off for that. I'm far too broad, and I have my tea at tea.
I have raised my hand.
I can't talk.
Okay, in that case, if there aren't any more questions, I'll take the opportunity to thank the panel very much for their participation. I found it particularly interesting. Oh,
Sep, I think you've got one question.
I have. Hello, Jane.
Oh, hi. I was just about to lower my hand. It was a question really for everybody. But perhaps, Steve, you'd like to start. I just listening to all of the discussion around collaboration, and there's a lot of that goes on already. But the elephant in the room is always the system integration, the data sharing principles, and we get caught up in IG debates that seem to take 6 months. Now, we've managed to crash through some of that by sheer necessity. Do you think we've matured quickly enough now to build a platform to go forward on?
I think we have. I think Phillipa and Jim would be a better place to answer that. But I think that my opening statement, the thing I said about what we have to acknowledge is we will not go back. We will not lose the gains we've made by COVID. There's an absolute commitment from the most senior level in the NHS to not give up everything we've gained. So my honest view is yes, but time to tell. Phillipa?
No, I agree. I think we have made gains, and we have probably smashed holes in some of those things that you do think, oh, but at the end of the day, they're not anything that we're putting our patients at danger with, and we should be sharing that information. We should be sharing that information. And lots of citizens think we already do that, but we don't.
Yes.
And I think when you look at certain places like Estonia where they share their information, you know, these are places that we need to sort of aspire to in respect to some of that mandate around actually getting people to opt out rather than opt in. I think that's really key. But also, we've already worked on that here. We're already liaising with our CCG about providing IG services, because we need to stop those silos, and we do need to stop that bureaucracy. But actually, we need to have one conversation. And I think we've had that. So I can't see it going back. I think it's something that we need to push forward for. And really put that on the agenda. But personally, it's happening, and it's for leaders across the organisations to absolutely mandate that.
Thank you.
Okay.
I think I just wanted to add to that, Jane, and thank you for that question. I think I have seen opportunities that we've been able to push through on the element of the relaxation of rules, the formal kind of, I know a lot of things get stopped by IG, but we'll sort of let it swing a little bit. Now, I always saw IG people as the people who have the easiest job because they just say no to everything. And so we were able to, and I don't mind saying this, we were able to not necessarily share data, but we were able to get more clinicians in a room on a Zoom call to be able to discuss fracture management and trauma cases or orthopaedic problems and actually help people on the ground, and got me thinking about how you get more eyes and ears on the ground, which is ever more important now that we're splitting hospitals into green, blue, amber, whatever colour you want to choose, but actually trying to segregate hospitals, which is very, very difficult. And if you can't relax those rules of how you share information, it took me, even in COVID, it took me about 4 or 5 weeks to get messages back from NHS Digital and from my local trust about whether it would be all right if I conferenced clinical information. And I've got a project about the use of head cameras to try and get some expertise from home. Your clinicians are watching Netflix, self-isolating, and you've got nurses on the ground using ITU machines that they've never touched for 20 years. Then I think there's such a dichotomy. But the opportunity in COVID was that we could suddenly do that. And I think what we need to embrace is when we get back to the table with the IG people, nationally or locally, then we can say, but we did that during COVID, and what was the worst thing that happened apart from good things?
Yeah.
Well, I don't think we can look back because we've done the proof of concept now. We could never have got to that proof of concept. My headcam idea would have taken 10 years. But I managed to get a conversation at Prime Minister's Cobra meeting within 10 days of trying to find a solution for this. And so that's how quickly things were getting up, and to have those examples of really good illustrations to IG people to say, if you share data, look what good things can happen, and that's patient safety.
Yeah,
Absolutely.
I think we've just got to be, and it's not cautious, but it's the other side of that, is in everything that we've done. IG is one issue, but cyber is the other. And I think as we become more digital, that's a key topic that we need to be really mindful of and not let our guard down. And that certainly we haven't here, but sometimes that is quite restrictive. So I think on the IG arm too, there's another arm to that around cyber security and how we manage that safety, because obviously that could be catastrophic.
Jane, does that answer your question?
Lovely, thank you. Coming from the perspective of a community trust, sometimes between the sledgehammers of acute and primary care, this management of information across those groups of clinicians is a real struggle. But you know, the ways have been eased over the last number of weeks, and I'd be somewhat devastated if there was any real, pull back to type and we lose that. So.
And I think I would also challenge around like us is around doing that collaborative piece and hosting some of those posts together and bringing those posts together, because around an ICS, ICP is the only way forward to break those silos.
Absolutely.
Can we challenge people, Jen, to just say no is not an acceptable answer?
I do try that one, Steve, quite regularly.
Yeah, I do. I have in the past said, here's a question and the answer cannot be no.
But if you say no, you've got to give me a different answer. If I can't use Zoom, you have to give me something I can use, and you can't tell me it's not ready yet. So I don't have a VPN. I'm going to use Zoom. What's the worst that's going to happen? Jim's words, not mine. People just have to say what our choices are, and then we have to take balanced decisions on that basis.
Well, the example I had actually recently was actually then speaking to a private company who realised, and I was saying, there's a lot of people in the NHS who can't work from home, whether it be admin, back office staff, or clinicians, and this company were able to put up, like within a few hours on a Sunday afternoon, we're able to step up a facility, a platform to be able to do that. And it could otherwise have been stopped with needing IT resource. They needed 10 minutes of IT resource to be able to do a whole hospital. And they were getting conversations at Cobra, and they're getting conversations in amongst other organisations. It got nowhere locally for me because it was just such a hard thing to try and crack. Because actually we could have solved a lot of issues in 10 minutes.
I think we should all accept that no is not an acceptable answer.
Yeah.
I always use the 5 whys, and it's really difficult.
Really important.
The 5th.
Really important.
Yeah.
Thank you. Thanks for your question, Jane.
Thank you for your question.
Lovely. We have literally got 2 minutes until the half hour, so I'm going to call it a day at that point. But I am going to say we've had some very nice comments. Thank you in the chat. People found the session very interesting. If anybody would like to send in any other questions, if you'd like us to try again, I might see if I can get these lovely people together again for another panel session, for another debate at a later point. So we'll leave you there. Thank you all very much.
Try and be more argumentative next time.
Yes, you won't be quite on your best behaviour maybe next time. Lovely. Thank you all very much.
Thank you.
Thank you, everybody.
Thank you.
Nice talking. Cheers.
Who's on now? Is that
I'm not sure who's left yet.
It says 1 left, doesn't it?
Is that just you and I?
I'm still on.
And Tara, shall
Yeah.
I quickly just ring Steve and Jim, and we can just do a quick.
Just round up.
Yes, well, I think we can hang up. Oh, sorry. We've still got Ken and Neil on.
Okay.
As the host, can you not hang them up?
I don't know. A couple of them are our people.
Hello.
Unless it's just telling us. Shall we hang up and shall I ring you all on a different team?
Yeah, that I think that'd be better.
Oh,
So-
Kenny's calling us, so he might be doing exactly that.
Hello.
I've got you again.
Hello.
I thought I'd answered that other call. Did Kenny try and ring you?
Kenny's on, isn't he? Came off it.
You back on?
He's just on mute. There's
Hmm.
Neil I.
Oh, hang up, Phillipa, and I think we'll try and ring you.
Okay.